Hello, everyone, and welcome to the sixth season of McGill Cares, a webcast series supporting family and informal caregivers of people living with dementia. I'm Claire Webster, a former caregiver, certified dementia care consultant, and founder of McGill University's Dementia Education Program. I work with a dynamic team of leading healthcare professionals to oversee the program, who include Dr. José Moret, from the Director of the Division of Geriatric Medicine, and Dr. Serge Gauthier, Professor Emeritus in the Departments of Neurology and Psychiatry. McGill Cares is supported by the Amelia Saputo Community Outreach for Dementia Care. The McGill University Dementia Education Program offers a comprehensive range of free multilingual resources to educate and support people who are living with dementia, their families and caregivers, healthcare students, and medical professionals. We invite you to visit our website at mcgill.ca/dementia, where you can access educational guides, online courses, activity videos, virtual support groups, and more. Everything is free for you to access. Since launching this webcast series in May of 2020, we have interviewed 116 guests and produced over 130 episodes. So today's topic is caring for someone with dementia, what you need to know about hallucinations, delusions, and paranoia. I'm so glad that you can join us for this important conversation with Dr. Simon Ducharme, a neuropsychiatrist and a clinician-scientist at the Douglas Mental Health Institute and the Montreal Neuro. He is specialized in frontotemporal dementia and the interface between psychiatric disorders and dementia. He conducts research on novel dementia biomarkers and clinical trials, including gene therapies in frontotemporal dementia. Dr. Ducharme holds a Senior Clinician-Scientist Award from the Fonds de Recherche du Québec and is the author of over 180 scientific articles and 8 book chapters. He's the director of the McGill Division of Geriatric Psychiatry and Neuropsychiatry and the Associate Chair of Research for the Department of Psychiatry at McGill. He is also a fellow of the American Neuropsychiatric Association. If you're caring for a person who's currently exhibiting these symptoms, we sincerely hope that today's webinar will provide you with a better understanding of these behaviors, because we definitely have one of the leading experts in the field, if not in Canada, but I'm sure on an international level. Dr. Ducharme, welcome to McGill Cares.
Thank you for the invitation, Claire.
So let's begin. If you can please help us understand why dementia sometimes leads to symptoms such as delusions, hallucinations, and paranoia.
Sure. Maybe we can start with some definitions. So hallucinations refers to a problem in perception of sensory inputs. So the person will be perceiving a signal that is not real or existing. So this could be hearing things, seeing things, perceiving things on their body. So the person will feel that this is happening as a reality, but it is a creation of their brain. So these are hallucinations. They're more sensory phenomena. Whereas delusions are beliefs. So the definition of a delusion is a fixed false belief that cannot be reasoned with logical arguments. So we often see them together, hallucinations and delusions, but we can also see them separately. We see these symptoms quite frequently in various dementia syndromes. We can see them at various stages of the illness, usually more on the more advanced side, but sometimes we can even see them as signs of early presentation of the disease. There are 2 reasons biologically why we see those symptoms. The first is that the brain systems that generate these hallucinations or these beliefs can be damaged by the illness. So you'll have degeneration in brain areas that are responsible for this, that are creating those symptoms. And then secondarily, because there are cognitive deficits, the person might have difficulty reappraising their thoughts. So if they have a thought about someone stealing from them, they might not have the capacity to logically reason to change that belief. So these are complex symptoms that are due to the illness, to Alzheimer's disease or other types of dementia. And that can be very disabling for patients and very difficult to handle for their caregivers.
So are these symptoms specific to certain types of dementia, or can they occur during different forms? Because, so for example, are there certain types that appear during Alzheimer's or Lewy body? So like, what's the difference?
Yeah. So we can see hallucinations and delusions across the board in all of these dementias. However, there are some types that can be indications of one disease being more probable. So the classical example is in Lewy body dementia. They typically have very vivid visual hallucinations. So they will see people, they will see animals, and they're going to be very clear visions that the person has. And they tend to happen on the earlier signs. So when we see a patient with a combination of cognitive decline, severe visual hallucinations, and often these patients have some motor symptoms that look like Parkinson's, this is quite typical of Lewy body dementia. In Alzheimer's, we tend to see more delusions, so false beliefs. And these stems from the memory impairment. So as probably many people listening today know, one of the core early symptoms of Alzheimer's disease is short-term memory deficits, so forgetting recent information. And the brain has this natural tendency to want to make sense. So if I forgot something, my brain will try to create a story of why something happened. So a classical example will be because patients with Alzheimer's tend to misplace objects and they forget where they put them, they will try to find their keys, their wallet. They do not find it where they think it should be. And because they're not fully aware that they have forgetfulness, then they might come up with a story that someone stole it from me. And if someone stole it from me, maybe someone entered into the apartment. And these beliefs can become very, very intrusive and invested by the patient, and they might want to argue. They might become even agitated if they're confronted about it. So it's this combination of brain distortion creating symptoms and then misinterpretation of information.
So you just gave an example, because that's what I hear a lot when in working with caregivers, is that they believe that somebody has stolen something from them. But there's also the aspect of, somebody is cheating on them, right? Or, we hear oftentimes, so men who are in the early stages too, who are running companies, may have been making unfortunate business decisions. Could you expand a bit on that?
Yeah. So there's some themes. So delusions are not just random thoughts. There tends to be patterns about what is it that people falsely believe. And interestingly, these themes tend to be a little bit different in dementia than they are in schizophrenia, which is the severe psychotic disorder that we see in younger people. In dementia, I would say that the three most specific themes are delusions about theft. So, and this one is really due to the cognitive loss. Someone stole my things. Someone didn't tell me on purpose about something. These kind of beliefs that stem from having forgotten information. The second one is one you mentioned, the one about jealousy. This is very common in Alzheimer's. It's very common in Parkinson's disease and vascular dementia. This one probably comes from some misinterpretation of signal, thinking the caregiver should be there when they told them they wouldn't be there. So they're trying to make up a story about why the person is not there. They lied to them. Why would they lie to me? Maybe it's because they're having an affair. The person with the disease also becomes quite dependent, so they're very vulnerable. So they misinterpret signal of absence as something ominous. So we have theft, we have jealousy. The other one that can be a little bit more peculiar, that we almost only see in patients with dementia, is what we call misidentification syndromes. So these are bizarre beliefs around the fact that their family loved ones are imposters, have been replaced by other people who look like them, or various combinations of that. It could be that I recognize this person. This is Bob. He's in the house, but my real spouse is someone else. So these can be particularly distressing for caregivers because they're being accused of being strangers or not the person they are looking for.
And I've even heard of, I've just recently actually, somebody believes that they were being spied on, that they have somebody is listening to their phones, they're being, there's, that they feel that there's listening devices that have been put into their home.
Yep.
So is that also something
That's
that,
something that can be seen. This is a symptom we'll see more commonly in major psychiatric illnesses like schizophrenia or substance abuse. So this is a very common theme of paranoia.
Hmm.
So it's not necessarily that typical of dementia, but we can see that they might want to monitor what's happening outside, look at the windows, concerned that someone might be threatening them. Another thing we can see are errors around familiarity. So thinking you are not in the right house, that this is not where you live, that you live somewhere else. That's also another delusions that we regularly encounter.
So when we talk about then hallucinations, like for example, I've heard of cases where people who are living in an apartment building where there is even no balcony or terrace, they're convinced that somebody is going to come in through a window. They see things. We've heard people think that there's a robber in the house or somebody. What can you explain that a bit in terms of hallucinations?
So hallucinations really implies that there's a sensory input, that is, the person sees something or hears something. So they can literally see in front of their caregiver, say, look, there's this person in the corner of the room when the person is not there. So they genuinely see it or hear it or feel it. So we have to make a distinction because sometimes it is not hallucination, it's more erroneous memory. So the person will say, my friend so and so was there today. And then the family might think this is a hallucination because the friend didn't go. Whereas this is probably just a mix up of memory in terms of when things happen. A hallucination is really in real time. The person will tell you, I see this person in the corner of the room. And indeed, like you mentioned, these hallucinations can be at times bizarre or improbable. People flying in from the balcony, animals walking in the room. They do not tend to be threatening. They're generally fairly neutral or pleasant hallucinations. The the person generally has no insight or a little bit of insight. So that means that when it's happening, they do tend to think it's true, but you might be able to reason with them after that it probably wasn't true because of so and so. And then they might be able to say, yeah, you're right. So they're not necessarily as invested in those hallucinations that you would see again with diseases like schizophrenia or schizoaffective disorder, where patients will give enormous meanings to their hallucinations. In dementia, they tend to be a little bit more neutral. And that's important to evaluate for interventions.
Mhm.
So we'll be talking later about what do we do about those in terms of treatments. But one key aspect is it disturbing to the patient? Is it making them upset, anxious, agitated? Does it influence their behavior? I remember a long time ago, I saw a patient who was seeing children outside of their balcony. So they had this tendency to want to go save them, and they were putting themselves at risk of falling over the balcony. So this would be a reason to intervene. But if it's just occasional hallucinations that the person tolerates, can be even a bit amused, this wouldn't be reason to intervene with treatments like medications.
So knowing that dementia has three stages, you've got the early and the middle and the late. Can you explain, like, because I get the question a lot from family members, like, how long is this behavior going to last, right? So, somebody, for example, who starts presenting it in the early stages, like the changes in personality and all those errors, how long does that last? Does it disappear as their communication skills disappear, or and the second part of the question is, could somebody suddenly start developing these symptoms at a certain point?
Yeah. So all the behavioral psychiatric symptoms of dementia can come and go. Usually not rapidly, but there tends to be fluctuations over the long course of the disease. So it's very hard to predict if someone that has a symptoms like a delusions of cheating or other will maintain that symptom for a long time. Uh, what often happens is that the symptom that could have been very disabling at first become a little bit less worrisome. So one example would be at the beginning of the disease, the person has a lot of energy and is combative and might be very agitated because they think the spouse is cheating. Whereas at the end of the illness, they may still have the thought, but they're more physically limited, more apathetic. So the symptom does not cause as much dysfunction as before. Um, it is a principle of treatment of all of those psychiatric symptoms to, when you intervene, to always revise every 6 months if the treatment is still required, because they might naturally fade away.
So these symptoms are very distressing on caregivers, and oftentimes when I meet with families, they feel like that they're all alone, like this is only happening to them, and we know it isn't. So in your practice, can you talk about some of the most common emotional and like what are the emotional challenges that when families are sitting in your office saying to you, like what are they feeling and what's the impact on them?
Um, there's a very natural emotional response of anger and frustration, because often the spouse, the caregiver, will be implicated in those delusions. So if there's a theft, if there's an affair, often it will be turned toward the person that's most often there, the caregiver. So you are put in this situation where your spouse has a disease, you have to cope with that. You become a caregiver, so it's very demanding. And on top of that, you're being constantly blamed, accused, or even potentially threatened because of that. So this is really a very challenging combinations of factors that can be exhausting for caregivers. So part of the work is really to understand the nature of the symptom as being a symptom of dementia, being an involuntary symptom, that this is not done by the patient out of spite or vengeance toward the caregiver. So, really understanding the nature of the symptom, that it's due to the disease, that it's fairly common, and that there is no gain in confronting the symptom. It will just lead to more argumentation and frustration. So there's a way to decrease the impact of those symptoms, but it is a very unnatural stance to take to being accused of doing these things and just letting it go and not try to convince the person otherwise.
Yeah, it's hard for people to not take these accusations personally. And one of the challenges that I see also is if you're guiding a family member on, how to communicate, but not the other family members haven't had the time to learn also these skills. Other family members may continue arguing and fueling the fire.
Yes.
And let's say the wife is doing her best to have a communicate with the husband, but then the husband gets into an argument with the son because he's refusing to understand that this is the illness causing that, right? So, how important is it for families all to be educated on this disease?
Yeah, I think cohesion is important when you're working with someone who has a loss of autonomy due to a dementia syndrome, uh, it is important for us to involve a wider network because often it falls on the spouse and then it's very draining. Often the spouse is more on the older side, and so there can be a lot of vulnerability. So, really encourage people to early on involve close friends, children, other relatives to help out. But once you bring in more people, indeed, that can create different dynamics. And so we want as much as possible everyone involved to have consistent approaches, messages, routine, uh, while also being realistic and empathetic toward everyone that, it is frustrating to be accused of this and that. And we don't want also to overly blame people for having very natural human reaction of being upset. But if this happens, it's always better if you're getting upset to just say, let me just take a bit of time. I'm going to go outside, go for a walk, take a break, involve someone else, than to argue with the person with dementia.
So before we start talking about like some of the medical interventions that can help, I guess we always want to look at the non-pharmacological interventions, right? Like what can we do to try to diffuse certain situations? So can you provide some like advice and strategies to caregivers? How do they respond if when their loved one is going through a whether that be a paranoid episode or having these hallucinations? Like
Yeah.
what do they do?
Well, first step is, does there need to be an intervention? As I mentioned earlier, if the person is calmly talking to themselves in the mirror because they're perceiving there's someone else, they're not agitated, they're not angry, they're not overly distressed, it keeps them occupied, maybe there's nothing that needs to be done. You will be creating more problems by trying to go break this or say, no, there's no one there. So sometimes doing nothing is the right thing. Uh, then, if you do sense that there's agitation, there's escalation, there's tension, there's distress, and you want to do something, it's always best to avoid confronting the patient about the symptoms. So, not trying to convince them that no, you weren't cheating, no, you didn't steal from them, no, there's no one outside watching us. Because of the nature of a delusion, the belief will not be changed by any sort of logical argument. So the way to reassure someone who is in an episode like this is more through a very calm, non-confrontational conversation and trying to shift them to some other activity, a distraction, something they like, music, going outside, changing room, anything that will shift the attention away from the current ruminations, so that just naturally the patient will just move on to something else and maybe even forget that 10 minutes ago they were angry and yelling about their jealousy. Um, so you also want to be safe in the way you approach the person because it's not that frequent, but we can see physical agitation. So make sure also that your intervention is safe and then just try to distract. Maybe sometimes it can be involving someone else, maybe getting an adult children on the phone to talk to the person to just shift the mindset. Um, what we want to do as well, non-pharmacologically, is try to identify triggers. So sometimes there's a pattern. These hallucinations or agitation will happen at specific times of days. Maybe it's linked to some physical symptoms. They need to go to the bathroom. They need to be changed, or they're hungry. Some kind of basic physical need that leads to more agitation. So you want to try to see over time, can you identify some triggers, some patterns? And if yes, is there something that maybe you can change in the routine, in the physical space to decrease those triggers?
I find oftentimes that the advice exactly that I'm providing with caregivers is you have to do what you can to try to like let go of who the person was and embrace who they're becoming.
Yep.
And oftentimes family members They're spending too much time telling the person what they can't do anymore. How come you're not doing it like this or doing like that? And I always say, like, if what they are doing or what they are saying isn't hurting anybody, let them be, right? But I feel a lot of times that agitation comes when the spouse or the kids are saying, well, why are you setting the table like that? Why are you dressing like that? Why you're always they're doing what they're doing because they have this illness, right? But it's oftentimes the family who just can't let go of who they were. And
And this is particularly true at the beginning of the illness when the symptoms are more recent, they're milder. So there's often this fantasy that maybe they're doing it on purpose, like
Mhm.
they're able to do it, but they're doing it wrong on
Or they're being
purpose.
lazy or they're being stubborn, right?
Exactly, exactly. Then over time, as the illness progresses and it becomes obviously disabling, then this type of reasoning tends to disappear in caregivers. But at the beginning, it is a less threatening thought to think my husband is being annoying because he's lazy than he has this degenerative illness that will make him lose autonomy and bring him to death over time. So sometimes there's a defensive aspect also to this need to confront the person.
So, at what point, though, would any of these behaviors become dangerous for the family? Like, at what point do we say, okay, this is now going too far? So, can you explain, certain like triggers or certain warnings that, okay, we need to go and get medical attention as soon as possible?
Yes, so I would say there are different scenarios. So the first one is when the person with the dementia endangers themselves because their behavior is influenced by the belief or the hallucination. So if I'm going outside in the street because I think there's someone on the other side of the road where my judgment is impaired because I have these hallucinations, that would be a reason to treat. Uh, then there's the impact on people around them. So if the behavior or the symptoms becomes dangerously exhausting to caregivers. So one example would be agitation at night. So the person with the dementia has these scary beliefs or these hallucinations, and they constantly wake up people in the room and their caregivers. And so they're not necessarily physically threatening, but this will not be sustainable over time if the caregiver can never sleep. And then there can be physical threats. So it's not the majority of patients, but it can happen that a patient with dementia, in their state of inner agitation or false beliefs, they might throw something, push someone, pinch someone, and this is not something that should be tolerated.
And I hear that a lot. And these are facts that sometimes family members don't want to admit. Sometimes you have to dig. Like, I'll hear sometimes where the person has gotten so angry and the spouse doesn't want to say, yes, my husband or my wife has thrown their cell phone at me or thrown the remote control. Or I've heard cases where somebody's woken up in the middle of the night and not recognized their spouse and has physically tried to assault them. But I think it's important that people realize it's not their fault, it's the disease, but do not put yourself in such a dangerous situation.
Very well said.
So, what type of medication would be used? Because that's a question a lot. Like do you have some generic names? Like what is the types of medication that you would prescribe to help and how long do people need to be on these medications for?
So, for symptoms of delusions and hallucinations, the good news is that although not perfect, medication can be very helpful to very significantly reduce the intensity of the symptoms. So, it might not make it completely disappear, but it decreases the intensity so that it leads to less emotional crisis and agitation. So we have medications for delusions and hallucinations are the family of antipsychotics. So psychosis means symptoms of losing touch with reality. So essentially hallucinations, delusions. So medications that have been developed for severe illnesses like schizophrenia can be used in very small doses in patients with Alzheimer's and other types of dementia for these symptoms. So we commonly use medications like risperidone, quetiapine, aripiprazole, brexpiprazole, haloperidol. There are several medications that can be used for these purposes. What is very important is that these are older patients with fragile brain to the degenerative illnesses, so they tend to be very sensitive to side effects of medication. So we always start with very small doses that we can increase slowly over time to make sure they don't have adverse reactions. And often just a small dose once per day, twice per day is sufficient to decrease the intensity of the symptoms enough that there's less dysfunction or danger around the symptoms. So that's the most common interventions. There are also medications, other classes we can use for agitation. Sometimes we use some types of antidepressants or mood stabilizers. So there are a lot of approaches. The key is to be very systematic, small doses, and revise treatment every 6 months or so. So even at low doses, the antipsychotics can have a few side effects. There can be sleepiness. There can be neurological side effects like rigidity or tremors, or they can be associated with weight gain. Usually, when we prescribe them at very small doses, we do not get into these problems, but this should still be monitored. There are patients, particularly in Lewy body dementia, who can be extremely sensitive to those medications, so we have to be careful. You will also see if your loved one is prescribed one of those medications that they carry a black box warning because there have been large epidemiological studies showing that there could be a very small increase in risk of stroke and death in patients with dementia taking those medications. So they should not be taken lightly or prescribed to everyone as soon as there's a bit of agitation. However, if the symptom is disabling, dangerous, distressing, sustained over time, it is generally quite beneficial to use them. So we see both concerns. Sometimes we're concerned that there's some overprescription, often in nursing care homes or institutions. But we also see family who are overly scared about medications and who will tolerate dangerous behaviors for too long because their fears of medications are excessive.
And I think for what people also need to understand that it takes sometimes a little bit of time for these medications to work. I hear from families who say, well, the doctor prescribed the medication, it's not working yet, but they've only been trying it for like 2 days, right? And
Yes,
as you mentioned, sometimes it's trial and error. You start with a small dose, but the person may need a bit more, and it may take a month or even more to find the right dosage depending on the person.
that's correct. And so a rule of thumb is that with every most psychiatric medications except the short-acting benzodiazepines, which are short-acting, but medications like antipsychotics, antidepressant, mood stabilizer, you need at the very minimum 2 weeks to start to see a signal, and generally up to a month. So you start at a low dose, you see if there's a bit of signal after 2 or 4 weeks. If not, then you increase the dose. So it's a slow process over time.
So one final question is, so how can family members, specifically caregivers, best prepare themselves for, a diagnosis of dementia, that whether or not it involves any type of psychological behavior or challenge behavior? What do you tell people when?
Well, so it's hard for me to tell them how to prepare because usually when they see me, it's to get the diagnosis. So I don't know how they could have prepared in advance. Um, what I always encourage people to do is to get some education about the disease. So go see websites specific to Alzheimer's, FTD, look at the McGill Dementia Education Program. There's really a big role for learning about the disease. It helps demystify the behaviors, the symptoms. It decreases the blame on the patient with the disease. And then you want to reach out to other people around you. So these will be long diseases. It will be challenging to care for the person for many years, usually. So you want to involve adult children, friends, family. It's always best to avoid just sometimes there's a bit of shame. So people we want to keep it just inside the immediate family, but it's good to reach out and ask for help from family, CLSC, home services, Alzheimer's Society, and others. So there are ways to make the burden less difficult to handle over time.
Thank you so much for joining us today, Dr. Ducharme. We are actually working on a series of videos for which Dr. Ducharme is involved with to support people living with dementia and their care partners. And many of these videos will focus on challenging behaviors, including wandering, agitation, aggressive behavior. And so stay tuned. If you subscribe to the McGill University Dementia Education Program newsletter, we will be launching these videos at the end of this year. And for education, please feel free to download our dementia education guide that's available in 14 languages. And we do cover and offer lots of advice about managing challenging behaviors here. So this webcast is an initiative of the McGill University Dementia Education Program, which is funded by private donations. If you would like to make a donation to our program or for more information, please visit our website at mcgill.ca/dementia. Thank you for watching.